And welcome back to Jeff Koinange Live here at Citizen Television, here with Dr. Sally Correa. She's an OBGYN in Spain, one of the epicenters of the COVID-19 in Europe. And Dr. Githinji Gitahi, the Amref Health Africa's global CEO. Dr. Sally, let me come back to you and just tell us for a moment, people in Kenya who just don't understand what 30,000 deaths mean, because our death toll right now stands at around 200 plus minus, let's say 200. You guys, 30,000 plus. I mean, help us, explain to us what that means. The numbers are numbing.
That's correct. That's correct. Now, both Italy and Spain were absolutely in shock. The psychological effects of having so many deaths in such a short time. Just to give you an idea, Jeff, when the deaths started in Madrid, they didn't stop, because COVID is like that. Once the deaths start, they're exponential, they double, and they don't stop. So there was no space in any cemetery. They had to put up the dead bodies had to go into a skating rink because of the temperature, and in Italy there was mass movement by the army because the cemeteries in the north were full. So I don't want to concentrate too much on that, because the word death is frightening. Spain and Italy lived with that nightmare, but it's real. It was people who I knew. I have a very close friend from church. Her father came in. She called me. I was at work, and she said, "My dad's just come in. We're on the island," and he was the first death. And all she could do was leave her father at the hospital because there was isolation. And she didn't see her father. He passed on 4 days later. So what I want to make clear is the kind of grief that happens with COVID when the numbers keep going up is very peculiar. So mitigation and preventing is our only hope, because there were no goodbyes said. There was no seeing your relative. The hospital, you were isolated as well. You got sick. Our first case here on the island was a young man from Italy who told his father to come and visit. And his father came in and was one of our first cases to be admitted. And 2 weeks later, he was admitted, and he was 40, and he was in the ICU for 3-4 weeks. So the kind of deaths that you see and the numbers keep rising, it's very real. It's very real. Everyone you get to know or hear, especially from Madrid, has had a relative or a friend. So it was, for the population generally, it was harsh. It was harsh.
Yeah, let me go to Dr. Gigi and say, Dr. Gigi, I mean, those numbers are scary, not only numbing, but scary. And yet at the same time, the whole world is looking at Africa and saying, why aren't those people dying like flies? What is it that we've done? Or is it because our population is mostly a youthful population, and that's why, and in Europe, it's mostly an elderly population? Could that be one of the reasons?
There are several factors, Jeff, you need to look at. First is the trajectory or the movement of the pandemic. There is something that Dr. Saleh said, that watch air transport. The air transport is not the issue. The issue is mobility. Watch movement of people. This is why when you have an epidemic like this of a highly infectious virus, when you slow down movement, you slow down the transmission. So if you look at Africa and you look at Europe and you compare what we call mobility index, or just level of mobility, the level of movement. Number one, if you look at rail in Africa, it's non-existent. Only a few countries have railway lines. When you look at Europe, the main movement is actually through rail system. So you move millions of people in a very short time from one place to another. Then you look at air transport, and you say, if you look at a satellite picture of airplanes across the world, you will think Africa, no one flies, because generally when you compare the rest of the world, the density of flight is very low. So this is an advantage for Africa so far. In terms of, even when you have the virus in one spot, moving it to other places is very difficult because the movement is very slow. I mean, we move in proboxes, on border. You know, we move very small people, very few numbers of people move across. What this says is that it's going to take much longer to see the peak than we did in Europe. The peak picked up in Europe, infection is what we are talking about, picked up in Europe very quickly because of this rapid movement, rapid transit systems of people. In Africa, we don't have that. There are people who are in one place for all their life. You know, so this is one advantage. So it doesn't mean the epidemic is not going to be there. It's going to take a longer trajectory because the movement of people is not too rapid. So that's number one, which then goes to the next stage then, which is risk. Now, as this trajectory moves, whether it's fast as in Europe or it's slow, it's infecting people. And within those people, it's a mixed random people, numbers of people. You have young people, middle-aged people, elderly people, people with hypertension, diabetes. So as you go along, as the numbers rise, then you end up with rising numbers of elderly people, hypertensive people, diabetic people, and then that's when you start to see critical care cases and death. Now, at that point, remember that if you look at the entire continent of Africa, only about 3 to 4% of our population are above 65 years. More than 50% of our population is below 19 across the continent. So the age factor, where age is the risk, if you look at Spain, Italy, those countries have a population of more than 65 years of up to 23, 24%, almost a quarter of the population is above 65. So you can tell that even as numbers rise slowly in Africa, the susceptible by age are fewer. So we'll see less critical care and less death required, happening because of age. But then there is another factor, which is hypertension and diabetes. Again, if you look at the number of people generally with hypertension, diabetes, smoking, and all those kinds of things, you'll find that actually there is because of the lifestyle in Europe, with fast foods, sugar, all these things, you have a higher rate of people with those risk factors. And therefore, you have also a higher death associated with the risk factors. This is why you are seeing South Africa has a higher death rate than any other country in Africa, especially if you look at total cases. South Africa is contributing probably 30% or so of the cases in Africa. It's because of obesity. Because obesity is a big risk factor because it leads to hypertension and diabetes. So the risk factors in Africa are different from Europe. Age, morbidity, comorbidity, hypertension, diabetes, obesity, they're different. They're much lower. That's why we are seeing a case fatality rate of 2% of the confirmed cases. And remember, the confirmed cases in Africa are underestimated because you have a much lower testing capacity. So actually, the case fatality rate, I would say, is much lower than 2%. Whereas when you look at those countries, up to 10%. But if you look at even Kenya, and you look at the people above 60 years, the case fatality is 16%. 16% of those who are positive above 60 are dying. So then it compares with other countries. So this is really, it's demographics, mobility, and all those factors that we need to look at.
How do you justify what Kemri said the other day, Dr. Gigi, that as many as 2.6 million Kenyans could test positive, in the next couple of months? That's 5% of the population, say, 2.6 million?
Well, it's 2.6 million will probably be at about 2% or 2.5% when you look at a population of about 50 million. But what Kemri did, and this study was done together with the Ministry of Health, was to say the tests we do to test whether people have COVID, all the numbers, the 9,000 we are announcing or 8,000, are based on checking the presence of the virus in the individual at the point of the sample. You take the sample from the nose or the mouth and you confirm the virus in itself. The proteins of the virus are present in that person. That's called the PCR test. That's the antigen test. You're testing presence of the virus. Now, if the other test you can do is to check whether people have the antibody, because every time somebody gets infected by a virus or a bacteria, the body produces bullets or ammunition against it. Those bullets or ammunition, we call them antibodies. They are antibodies fighting antigen. The antigen is a virus or the bacteria. Now, you can therefore test for the presence of the virus, which is what we are doing now, or you can test whether the body has actually met this virus. That's you test for the antibody. That's what KEMRI did. And they went and worked with blood storage. And they said, we are going to take blood that is donated across Kenya between April, I think it was April to June, and test all of it to see, a fair amount of sample. I think they tested maybe 2,600. See how many of these blood samples that were donated by Kenyans over the COVID period may have come into contact with the virus. They were not testing for the virus. They were testing for the possibility that these people had come in contact with the virus. And out of that, they then projected and said maybe 2.6 million people, based on the sample of 2,000, they extrapolated and said these people may have been in contact with the virus. Now, this could be true. There could also be errors in the antibody test because it has what you call error margins. But generally, it is not inconceivable that about 2.6 million people may have come into contact with the virus, especially knowing that 80% of our infections are in young people between 20 to 49 years, and therefore they may have had the virus, they were never symptomatic, they were never caught in the tracing because maybe they were in a matatu, and the person who was tested positive could only remember the driver and the makanga and the conductor and not the passengers. So it's possible that we have that. But because majority of them are young, the virus could have come, the body developed antibodies, overcome the virus and moved on. So it is a possibility, but this is extrapolated from a small sample.
Dr. Sally, let me ask you this. You were in an operating theater today. You're probably in an operating theater every single day. And the chances of folks in your position, ER doctors, OR doctors, getting the virus are very high. Do you get worried when you walk into that OR, even though you're dressed up and suited up? Do you get worried?
So it was a huge problem because we inherited from Italy. When the virus came to Spain, we inherited the news that 50 medical doctors had already died. And these were anesthesists, these were in the medical field, especially family doctors. So of course, when the virus was spreading in our community, testing was insufficient. We all know that. And I'm sure there are many viewers who ask themselves, why can we not get enough testing? But nowhere in the world that has been possible. Our testing kit is actually quite expensive. So with that said, we were fearful, and mostly because we didn't have equipment. This is the first world, but we did not have equipment. There were hospitals like Valencia where the doctors were wearing garbage bags and plastic. There was no equipment for us. We would easily get, especially in the operating room, there's blood, there's aerosol because the patient is under anesthesia. And the risk of infection is extremely high. So we were very worried, but when the lockdown came, it gave us a chance to get ready. So when the different phases of opening up started, what Spain did was make sure that every community had enough equipment. And that is why we are more comfortable now. And even though we have the cases rising, we are sure that we all have the equipment. But it was very frightening. It was very frightening.
Yeah, I can imagine. Dr. Gigi, you mentioned a moment ago, and you saw the pictures the last 48 hours, people streaming to all the termini, heading to the rural areas. And that's where the older folks are. Isn't it obvious that some of these people will be transporting this virus to the older folks? And yes, there will be a spike. Isn't it obvious?
It is obvious. We are going to get a spike. We are going to get a spike in the counties. That's expected. Yes, we are going to get a spike, Jeff.
Is that worrying, doctor? Because let's face it, everyone's rushing to go to Mashinani to take their kids because there'll be no school until January. So all the kids are going to be dumped with Shosho and Guka and out in Mashinani.
It is worrying. It is very worrying. And I think, the thing we have to remember, as we've said, is that movement of people is what transfers the virus. So we have kind of contained the virus in particular areas. We've seen the numbers in Nairobi, you've seen the numbers in Mombasa, and eventually you have to open, as we said. I mean, you can't lock down forever because you don't know when the virus goes away. And especially in Africa, where we expect a very elongated pandemic, then you have to open. Now, the question is, Are we going to see a spike? Yes, we will see a spike. We'll see the numbers rise. Are we going to see more risk of elderly people, and probably in some of the counties where we know they have a higher rate of what we call non-communicable diseases, diabetes, hypertension? You'll look at areas like Nyeri, Meru, central area, very high rates of some of these conditions. Also in terms of demographics, population distribution, you see older people in some of these areas actually than others. And then in some areas like Turkana, I saw a Cambridge study that was looking at some of these other risk factors, where areas like Turkana have a high smoking rate, and smoking is also a risk factor. So we expect the numbers to go up. We expect the people requiring critical care to go up because of now the elderly people and the people with these core illnesses or comorbidities. The question is, are the counties ready to take up these cases? If you have an elderly woman in Uasin Gishu, in Turkana, in Kiambu, or wherever it is, or Meru, who has difficulty in breathing, is the county ready to take that person, give them oxygen, and if they need an ICU, they give them ICU? These are the questions we need to be asking. But at the same time, Jeff, we need to ask ourselves individually, because we know that there are public health measures. Number one, we are told, avoid crowded spaces, avoid close contact, avoid close spaces. So even if you have to travel, and you must travel, because I have seen Kenyans rushing to travel. And this is what the president talked about, civic duty. Even if you have to travel, you can still take care and say, I have to travel because it is absolutely necessary, but I'll make sure I don't shake my grandmother's or my mother's hand. I'll make sure I am 3 meters away from them. I'll make sure I wear the mask all the time, and I'll make sure I wash my hands or carry a sanitizer, and I'm not in contact with them. This is important, that even as you go, if you have to go, you must think through yourself and say, what can I individually do? The tool is in your hands. This is what we need to talk to communities about.
Absolutely, and they're listening to you right now, Dr. Ari, and they're going to see these people coming from Nairobi and saying, that's where COVID is. We don't want these people here. So what do you tell them? Even those ones in Mashinani, how do they respond to the wave coming through?
Well, the thing about this is that, again, it goes back to civic responsibility. I know homes, and I have seen photos from Busia, from places where families have placed hand washing stations at their gate. And these are rural families. And they have said, if you're coming here, please wash your hands. We are inspecting that you're washing your hands. Number two, if you don't have a mask, please don't enter this house. Talk to us from the gate or talk to us from 6 meters away. And if you do not, if you don't belong to this community and you've come to visit or to hide, the Nyumba Kumi system and the social system should be able to approach you with the right respect and dignity and maybe have a discussion with you. Where have you come from? So the message to the communities is that this is your life. These are your loved ones. So be alert, be aware. Just the way when there is a malaria outbreak, people combine and they go out and they cut bushes together. This is the same. You don't want your children, your elderly people to die of COVID by being laid back. So even as we live, and we live knowing that we need to go on taking the measures we need to take, the people receiving you must also be alert that there is a possibility, as it was said the other day, everybody must be treated as a suspect, as somebody infected. And everyone must consider themselves as susceptible to the virus. Then if you do that, then you take the necessary precautionary measures to reduce the chance of transmission.
Yeah, Dr. Sally, I actually went to school with some of your brothers, and I'm sure your family, wherever they are around the world, they must be very worried about you over there. Must be sickly worried.
Jeff, you can let me just, I wanted to make a comment on two things that were mentioned that we've talked about. Now, when it comes to the phrase that says vulnerable groups, I mentioned this on Sunday. When we assume that COVID has vulnerable groups, we immediately insinuate that they are non-vulnerable groups. So let me explain that. If we have a certain list of medical illnesses and pre-existing conditions that make you more prone to presenting a more severe disease, that is what we've called in medicine the vulnerable groups. But the problem of using that term is that it makes all the other groups of people feel that they are not vulnerable to the disease. And because I have worked in Spain, and because I did my first and second degree in the north of Italy, and my classmates were really on the front line in Milan, in Bologna, these are the areas that were very many young people succumbed to the disease. Athletes, 24-year-olds, 18-year-olds, they succumbed to disease. And evidence of that can be seen in the US. In Arizona, after they carried out young people's parties, right now, the majority of the admitted patients are below the age of 44. There's a young man in Israel who was 24 and was admitted with very severe disease. He was a basketball player. So what I fear is, as I mentioned before, COVID will do what it wishes with the community it finds. And if we have a very high viral load, to give you an example, you're in a house party. The pubs are closed, so everyone has a house party. We're all young adults, and we feel we're invincible. So we have our drinks. Of course, with any kind of alcohol, responsible behavior cannot happen. What happens in this closed room, this house party, is the viral load increases because when we have community spread, we have, if it's a party with 100 people, let's say 50 people are asymptomatic carriers. And please remember that asymptomatic carriers are shedding the virus for 14 days. And if someone has a little bit of fever, they can be spreading that virus for 21 days. So we have this party, we're all young, we're all feeling good, but the amount of virus that is inoculated into our lungs can take us directly into a full-blown pneumonia. And another thing that makes our reality very different from the West is oxygen. So a 20-year-old in Spain will go to the hospital, get their oxygen. You are on oxygen for about 5-6 days, and they will go home. But in our setting, a young person, if we saturate our healthcare system, the oxygen option will not be there. And that will be an increase. That will cause our case fatality rate to increase. So the pattern of COVID-19 in the West cannot be identical to that in our reality. And Latin America is showing that. Ecuador is showing that. If there are not enough facilities, this young person who would probably have a little bit of a fever, go into the hospital, get their 3 or 4 days of oxygen, will succumb to the disease. So it is a disease brought by interconnectability. It is our first pandemic in a global world. It is not the same as any other pandemic. In 1957, the last Asian pandemic, flu, there was no interconnection in the world. There were hardly commercial flights. In 1918, in the Spanish flu, and the Spanish flu was brought by American soldiers to Europe, the probability of a woman in the north of Spain traveling to London was close to 0. We are now in a global world. Prevention is the only message, and everyone is vulnerable to this disease. And I must remind children, the children are asymptomatic carriers. Children will rarely present any kind of symptoms. So as long as we have interconnectability, be it a country bus, be it a boda boda who is connected very closely to his clients, we will not be able to flatten this curve. We will flatten this curve if 80% of our population is wearing a mask that covers, or a face covering that covers the nose. We will flatten the curve by 50%. But it'll require 80% of our population to reduce the viral load in the area. So it's a very important thing. We are not, all of us are vulnerable to COVID-19. And our healthcare setting, if it sees an influx, even the young, fewer cases may succumb to the disease. So I feel that's something, I'm very passionate about this. Yeah. We have 2 different healthcare settings. And Latin America is one of those. And America itself, the US, they have very many young people. They've had the first lung transplant was a girl who was 21. So if you observe a couple of things, it is the message is prevention is our only hope. Proper prevention is our only hope. Absolutely.
Dr. Gigi, let me ask you this before we go to break. It's actually a question from my good friend Maina Kageni. He says, let's talk about the elephant in the room. Just what does Tanzania know that we don't know? They've shut down nearly all their COVID-19 units, and yet they're not dropping like flies, or so we know. Is it just amazing PR from the government there, or they've convinced an entire population that this virus is harmless? If so, can we learn something from them?
Well, I would say that the response to the pandemic is a decision that every country makes. The fact that we have is that this pandemic is the same in every country. Now, do we know what's happening in Tanzania? We do not know, because no numbers are being announced for infection, no numbers of death are being announced. We do not know at all. So we cannot say that there is no mortality in Tanzania. We cannot say there is no infection in Tanzania. We can only say we do not know. But what do we do? We follow science. The world over, we say, follow science. And if we follow science, science tells us, as Dr. Sally is saying, preventive measures are important. They are going to help us to flatten the curve. They are going to reduce the rate of infection or transmission as we wait for a vaccine or as we wait to improve our health system. So we follow science. That's all I can say about Tanzania. And as far as looking from outside, Tanzania is not following science. What are they following? I don't know.
Yeah, you're right. We don't know. Let's take a break on that point, Doctor.
We don't know.
Doctor, we're going to take a break, come back. Dr. Sally, when I come back, I want to ask you both, actually. WHO now says this virus could be airborne. What does that mean? What does that mean? Let's take a break. Great conversation we're having over here with Dr. Sally Kuria, all the way in Ibiza in Spain, and Dr. Gigi, that's right, Gideon Gitahi, Amref Health Africa's global CEO. This is the kind of conversation we need at this time. Send in your comments, your questions at Koinange Jeff at Citizen TV Kenya, the hashtag JK Live. JK Live, takes a break. We'll be back in a moment.